Advanced degenerative disc disease that results in spondylolisthesis is a condition where the disc degenerates, resulting in a loss of disc height, causing instability, and one vertebra to slip forward over another one below it. Other causes of spondylolisthesis include stress fractures or congenital abnormalities, and in rare cases, a tumor or trauma. Degenerative spondylolisthesis is a consequence of the aging process, in which the bones, joints, and ligaments in the spine grow weakened and become less able to maintain the alignment of the spinal column. This type of spondylolisthesis typically occurs at one of two levels in the lumbar spine, L3, L4, or L4, L5, which is the most common. Degenerative spondylolisthesis is more common in people over age 50, and in particular among individuals over age 65. Women are 2 to 3 times as likely as men to be diagnosed. Spondylolisthesis can cause impingement of the nerves and/or fatigue of the back muscles, and may result in lower back and/or leg pain. Symptoms of spondylolisthesis may include lower back and/or leg pain, sciatica, an aching pain in the hips, buttocks, and lower back that radiates into the back of the thighs and legs, a shuffling gait when walking, weakness in the lower extremities, abnormal posture. If you feel that you are experiencing any of these symptoms, you should see a physician for an accurate diagnosis. If spondylolisthesis is established as a diagnosis, your doctor will likely recommend one or more of the following treatments based on your individual condition: physical therapy and strengthening exercises, rest and a restriction of physical activity, injections to help reduce the pain and swelling, medications and analgesics to reduce pain and swelling. Typical medications include nonsteroidal anti-inflammatory drugs. If your symptoms do not improve with other methods,
osteoarthritis is the most common form of arthritis and affects millions of individuals. It is classified as mild, moderate to severe. It affects many parts of the body, including the knee. The knee joint is made up of the femur, tibia, patella, along with the synovial membrane, which contains synovial fluid. Synovial fluid acts as a lubricant in the knee joint. The end of the femur is covered in articular cartilage, which moves against the articular cartilage of the tibia. In a healthy knee, the articular cartilage is smooth, without fissuring, and the bone is smooth. The synovial fluid is viscous, aiding in lubrication. The knee can move through its range of motion without pain. Over time, osteoarthritis affects the bone, cartilage, and synovial fluid of the knee. With mild knee osteoarthritis, you will begin to have discomfort in the knee joint. Though the joint space appears normal, the cartilage matrix has begun to break down from a combination of wear and tear and increased production of degrading enzymes. In addition, bone spurs, known as osteophytes, may begin to develop on the edge of the joint. These small, smooth, dense growths of bone are part of the body's natural response to the loss of cartilage. Progression of the disease may be slowed at this stage by increased exercise and weight loss. With moderate knee OA, changes in the joint are much more evident. The cartilage surface between the bones has begun to erode, narrowing the gap between the femur and the tibia. Hyaluronic acid, which helps synovial fluid lubricate the joint, is now becoming less viscous, elastic, and concentrated. Osteoarthritis often affects the subchondral bone, located just underneath the cartilage. Subchondral bone provides hydration and oxygen to the cartilage. As subchondral bone flattens and tries to repair itself, cytokines and proteins are released into the synovial fluid. Osteophytes may increase in number and size, making the bone rougher. All these factors combine to make joint pain more severe and long-lasting, both with movement and at rest. Weight loss and exercise, pain relievers, HA, or steroid injections are commonly prescribed treatments. With severe OA, conditions worsen dramatically. The joint space has become far narrower, causing more rapid and severe destruction of the cartilage. The knee becomes inflamed and sore. Synovial fluid is decreased, increasing friction and pain during movement. Within the synovial membrane, destructive proteins are produced which further degrade cartilage and soft tissue around the knee. Osteophytes continue to develop. Bone moves against bone, not cartilage. Mobility, activities of daily living, and quality of life are severely impacted. Treatment for severe OA is typically surgery by receiving a partial or total knee replacement. If you are suffering from knee osteoarthritis, speak to your physician to discuss treatment options.
Vitamin D. We have two types of vitamin D have been found in the nature. Ergosterol, which is produced from the plants, which is a provitamin called as D2, and 7-dehydrocholesterol, which is a provitamin called as D3, found in the skin. And what are the sources? And the sources where it is formed in sun exposed skin, and richest source is liver oil. And what about daily requirement? Adults require approximately 100 international units or 2.5 micrograms, whereas the pregnant as well as lactating mother needs 400 international units, and infants and children require 200 international units. Here you can see the metabolic pathway of the vitamin D synthesis. So here the vitamin D is synthesized in the skin from provitamin D3, that is 7-dehydrocholesterol, in the presence of ultraviolet light, and it is then hydroxylated to 25-hydroxycholecalciferol, which is also called as calcidiol, in the liver by 25-alpha hydroxylase enzyme, and it is finally gets converted into biologically active form of vitamin D in the kidney by means of an enzyme called as 1-alpha hydroxylase to form 125-dihydroxycholecalciferol, and finally the 125-dihydroxycholecalciferol, which is a calcitriol, is called as active form of vitamin D. So what about the functions of vitamin D? It increases intestinal absorption of calcium as well as phosphate by synthesizing calcium binding proteins in the intestine, and it is also responsible for mineralization of bones mediated through osteoblasts. And what about the deficiency manifestations? Rickets seen in children and osteomalacia in adults. So in rickets there is inadequate mineralization of bone, and it occurs before the closure of epiphyseal plate, typically in the children. And osteomalacia, where there is inadequate mineralization of the bone and occurs after the closure of epiphyseal plate, and renal osteodystrophy in adults. So this is the difference between the rickets as well as osteomalacia. And what about vitamin D excess? If vitamin D taken in larger doses, like approximately 500 to 1000 times of normal requirement for prolonged periods, so there are like immediate effects as well as delayed effects. So immediate effects are like thirst, anorexia, constipation and polyuria, followed by nausea, vomiting and diarrhea. And delayed effects, if you see, there will be hypercalcemia, urolithiasis, metastatic calcification and sarcoidosis. And this is about vitamin D.